Okay, so today we're going to be talking about GU. And here's going to be your terminologies for this section. I wanted to point out to this little area over here off to the side, I know we talked about it a little bit in the past, that some of these root words are going to be the same based off of what they mean. So, inflammation of the urethra, you're going to see that suffix right there in a lot of different words. So that should kind of help you out a little bit when you're talking about different terminology throughout med-surg. The urinary tract is naturally a sterile environment. The most important mechanism for maintaining the sterility is due to adequate urine volume. So think about your patient's hydration. The second component of that is going to be complete emptying of the bladder. So pathogens can enter and contaminate the distal urethra, but they're washed out when we void. The body also naturally produces mechanisms which include normal acidity and bacteriostatic properties of the bladder and the urethral cells. So when voiding occurs, there's going to be an increase in pressure that's going to compress the ureters and prevent reflux or backflow of urine into the kidneys. Men will also produce zinc in the prostate fluid, which helps to create an antibacterial effect. So the uritis is going to be the inflammation of the urethra. Prostatitis is going to be inflammation of the prostate gland. Cystitis is going to be an inflammation in the bladder. So we would have that right here. And then polynephritis is going to be an inflammation of the kidney and the pelvis. So risk factors for this. Women, of course, they have a shorter urethra, so the proximity of the meatus to the vagina and the anus makes a big impact on that. So think about sexual intercourse, use of a diaphragm or spermicide, and also increased risk during pregnancy due to hormone fluctuations. So men that are at increased risk are going to be those that are uncircumcised, anybody with prostatic hypertrophy, and then obstruction. So if you have obstruction due to a tumor or calculi, that's going to increase your risk. Aging is another issue. The older we are, we kind of tend to get infections more, neurogenic bladder, reflux disease, diabetes, and catheterization. So anybody that's performing frequent catheterizations, people that self-cath at home, they're going to be at an increased risk. So symptoms of a UTI, the manifestations are going to be dysuria, frequency, so they're going to have some urgency when they need to void, increased voiding at night, which is the nocturia, pyuria, hematuria, which is going to be your blood in the urine, and a suprapubic discomfort. So they're going to have some pain associated with this. They're going to have increased pain upon urination. The pyuria is going to be pus or infection, so they'll see pus in the urine, and when they do a urinalysis, that pus is going to come up as increased WBCs. Polynephritis, they could have some flank pain, and that's due to inflammation with swelling and edema in the kidney pelvis that can stretch the capsule surrounding and supporting the kidney, and that stimulates the pain receptors in the body. So special populations are going to be your pediatric patients. They're going to have a couple different symptoms that are going to be different than adults. So flu-like symptoms, fever, or hypothermia. And the elderly, which is going to be more what we're going to be taking care of, a lot of times they're going to have delirium. So delirium, confusion, incontinence, if it's not their baseline, lethargy, and fever or hypothermia. And I will post a copy of this on D2L so that you can watch the video that's listed here. but really no one should be having a fever for more than 48 hours without having their urine checked. There are, just as a side note, new policies and procedures at Unity Point for obtaining a urinalysis specimen, and a lot of times one of the things on the checklist is going to be a fever, so they would not check a urine without symptoms. And a Foley catheter, there is huge implications with having a Foley catheter with patients. With skip patients, we try to get those out fairly early. And if you think about it this way, with that tube that's in the bladder, you've basically just opened up the interstate for bacteria into their bladder, so that can just kind of flow freely. There's a lot of research out there on CAUTIs and preventing them, but just keep in mind for every day that they have that Foley in place, their risk for infection really increases substantially. And at the 30-day mark, they're 100% guaranteed to have a UTI. So there's different testing that we can look at to determine if a patient has a UTI. So urinalysis, they're going to be looking for a bacterial count greater than 100,000 per milliliter, and that's going to be indicative of an infection. Along with this, they're going to be checking a culture and sensitivity report to assess what type of bacteria it is to ensure that the antibiotic being ordered is going to cover that particular microorganism. So they're going to assess for pyuria, bacteria, and blood cells. They could be doing a nitrate dipstick, and that's going to be a rapid test for bacteria in the urine. The indicator will turn pink in the presence of bacteria when they do that test. They could do a leukocyte test, and that's also going to be a rapid test, and that's going to indicate the method for detecting bacteria by identifying lysed or intact WBCs in the urine. And those are just some examples of things they could be doing during the urinalysis. A lot of times, if these come back preliminary positive, they will go ahead and place the patient on a broad spectrum antibiotic, waiting for that culture and sensitivity report to come back. Always important to follow up on these as nurses, because it will tell you if the organism is susceptible to the antibiotic the patient's currently being treated on, or even if it's the best antibiotic of choice. They're also going to be doing a complete blood cell count, a CBC, to be looking for an increase in WBCs. And then there's a couple other tests they can do in the event that the patient has recurrent UTIs. So if they keep having UTIs over and over again, or pyelonephritis, they're going to be doing additional testing, such as the rest of these down here. So an IVP, that's going to be your intravenous pyelogram, and that's going to evaluate for any type of structural or functional abnormalities of the kidneys, ureter, and bladder. So this is going to be using contrast dye. So think about your precautions there. Patients with diabetes that are on metformin, patients with renal issues, that sort of thing. With the cystoscopy, they are going to be using that to diagnose any prostatic hypertrophy, urethral strictures, and bladder calculi. So we're going to be looking for stones. They can also detect tumors, polyps, diverticula, and they can do a biopsy this way. They can also do just a manual exam. They'll do a pelvic or a prostate exam to take a look at to palpate the different structures there. So when we're talking about testing, the most common one, of course, is going to be the urinalysis. And if you have a physician that just orders a urinalysis, you need to clarify that that's all they want, or if they want a culture too. Because if they're looking for UTI, they'll want to have a culture. And a lot of times they'll mistakenly order one without the other. So make sure that you get both. Think about how you're going to be collecting this sample. That's a really good thing to test on, would be how to collect a urine specimen. So think about how you would collect that. You want to make sure that this is always a midstream catch. You're going to educate your patient on proper cleaning if they're getting the sample themselves, or proper cleaning, educate your CNAs on how to collect them, make sure that you're collecting them properly. And then if your patient is incontinent, you might need to do a catheterization for a sample. So medications for UTI, I kind of touched on this a little bit earlier. So typically, you're going to have 7 to 10 days of treatment with antibiotics for pyelonephritis, and then 3 to 4 days with your lower UTI. So if you're looking at the urethra or the bladder, you'll do 3 to 4 days. So antibiotics are typically determined by the bacteria indicated in the culture and sensitivity report, like what we said. But initially, they're going to, when initiating therapy, the standard of care calls for use of broad-spectrum antibiotics, and that's going to cover organisms that are usually associated with infection in the urine. So the therapy is then streamlined after cultures and sensitivity reports are available. They do this because delaying any type of therapy with infectious processes are suspected is really not an option. So if you think about your patient, your elderly patient that is really confused and running a fever, they collect a UA, it's got bacteria and WBCs in it, they're going to get them on something to treat that right away because they don't want it to turn into urosepsis. They don't want it to get any worse. So they'll put them on something preliminary and broad spectrum to treat it, wait for that CNS, that culture and sensitivity report to come back, and then get them on something more appropriate for that organism. So let's say, going back to this one for a minute, let's say that the physician ordered a urinalysis but didn't order a culture. And the antibiotics have already been given. So really, culture should be done prior to administering antibiotics. That's really important because you don't want the antibiotics to skew the specimen. So if this happens and the urinalysis was collected with no culture, what you can do, if it's been within 24 hours, you can call down to the lab and have them run a culture off of the urine. So they'll keep those samples in place for about 24 hours. I think I kind of touched on this earlier, but there is some literature that indicates not treating UTIs in patients unless they're symptomatics. So the other thing is to consider if they're pregnant or having a procedure such as a catheter. So you would want to get rid of the catheter before starting them on anything. The other thing is pyridium. This is not an antibiotic over here, but it is a urinary analgesic. So that's used for symptom relief, so it kind of helps with the pain and the burning and the frequency. And this is usually going to be in effect for about 24 to 48 hours after they've started treatment. So you're going to get them on an antibiotic and start pyridium to help with symptom control. Be aware, especially if you're dealing with an outpatient situation, that this is really going to turn their urine orange, and it will stain just about anything. So teach the patient and the family regarding any urine color. You don't want to scare them by not preparing them for that. And it does not treat the infection, so taking this medication alone is not going to get rid of any type of UTI. So other considerations with this: stop taking this medication if the sclera or the skin becomes yellow tinged, and that's due to liver toxicity. One other thing, it's not a medication, but it does relate to UTI. Sometimes if your patient has recurrent infections and they're not sure what's going on with that, they will do a surgery, like a stent placement, to help decrease the cause. So again, not very common, but I just want you to be aware that it is a possibility with patients with recurrent UTIs. So one thing too to consider with this is, with UTI prevention, we're really looking at reducing the cases of pyelonephritis. So if your symptoms on your patient don't get better with antibiotics, let's say after 24 to 48 hours and they're just getting worse, they might need to be hospitalized if they're not already hospitalized and receive IV antibiotics. So pyelonephritis is going to be an inflammation of the renal pelvis and the parenchyma, and that is affecting the kidney tissue. So acute results from infectious diseases that are involved in the bladder are going to be traveling up to the kidneys from the lower urethral tract. So that hopefully is not going to be a very common thing for you, because we want to catch those things early before they become more serious. Usually it's E. coli that tends to cause that kind of thing. Onset of symptoms of pyelonephritis are going to be pretty rapid, with chills, fever, malaise. They could have vomiting, flank pain, vertebral tenderness, urinary frequency, and dysuria. And they could also have cystitis accompanying that. So nursing considerations to help with UTI is we're really going to push fluids if you're able to. So make sure that before you do this, that your patient doesn't have any underlying conditions that you can't increase their fluid intake, like heart failure. So push fluids, also be cautious with renal failure. Cranberry juice, that has been shown to help decrease the incidences of UTIs. Some people will also take cranberry pills too, in addition to that. Caffeine and alcohol, so you're going to limit caffeine, alcohol, and smoking. You're going to have these patients void frequently. You don't want that urine to be sitting in that bladder for too long. And then proper catheter maintenance, which you guys should be familiar with proper catheter maintenance, but I can go over it a little bit too. So you want to make sure that the bag is lower than the bladder, so that way it drains properly. You don't want any dependent loops in that either. So if they have a Foley catheter, you don't want dependent loops. And the bag should not be touching the ground. I also don't like it when those bags are too full, so I tend to empty them every single time I'm in the room. And then we have special wipes we use at Unity Point for pericare for patients that have catheters. And the other component for this is going to be your patients that intermittent cath or self-cath. A lot of times that's more of a clean than a sterile procedure, so you want to make sure that they're doing that properly. Antibiotic compliance is another big one. Sometimes when people get home and they have a 7 to 10 day course, they stop taking their antibiotics because they feel better, and then they end up saving them for next time. So we don't want patients to do that because that's how MDROs are made, and we don't want to have any more resistant organisms out there. Proper hygiene, another big one, especially with your female population. You want to educate them on proper pericare, proper wiping, wearing cotton underpants, that kind of thing, to help reduce the incidences of UTI. And education is a big point with these patients. A lot of people need a lot of education on this. You get this with the elderly people that don't want to get up and have to go to the bathroom frequently, so they won't drink as much water, or they'll try to hold it and not void as often. So you want to make sure that you educate them to stay hydrated, avoid excess intake of alcohol, avoid it if possible. Milk products can also cause that. And then a couple nursing diagnoses for these patients. They're going to have some acute pain, impaired urinary elimination, or even acute confusion. So those are just a couple with that one. So really address and educate your patients on not delaying their voiding and pushing fluids if that's possible. So urolithiasis, we're going to have some stones in the urine here. You see this one right there. There's one in the kidney, there's one in the bladder, so it can happen in different locations. So this is going to be the most common type of upper urinary obstruction. So they're going to be masses or crystals composed of materials normally excreted in the urine, and they tend to be made of different things. It just kind of depends on the person. So the cause of this is going to be by supersaturation, nucleation, or lack of inhibitory substances in the urine. And the risk of recurrence is about 50% unless they really reduce their risk factors. So that means if your patient is prone to getting these, like say they've gotten them once, they are 50% more likely to get them again if they don't stop doing what's causing them. So these are going to be stones in the kidney, ureter, or bladder. So renal calculi, those are going to be your stones that obstruct urine flow. They're going to impair renal function, and it's really a common cause of acute and chronic kidney disease. Lithiasis, that's your stone formation. So nephrolithiasis is going to be a stone in the kidney. Urolithiasis is going to be a stone in the urinary tract, and of course we've got one here in the bladder. So this is most commonly seen in young to middle-aged white males, and the majority of the stones are idiopathic. So that means we have no determining cause. And there are a number of risk factors that are going to be identified with this. So a lot of times it's going to be an increase in concentration of insoluble salt in the urine and a decrease in fluid intake. So here's a couple different pictures of different types of stones, and you can see they're all different shapes and sizes and even colors. So about 70% of these are going to be made from calcium, and that can be from high amounts of calcium due to diet or disease. Uric acid is going to be about 5 to 10% of those, and that's going to be due to high amounts of uric acid, possibly due to gout. So think about your patients with gout. Struvite is also an issue. That's about 10%, 10 to 12%, and that's going to be made of magnesium and phosphate. So those are going to be due to Proteus in the urine that's going to be splitting. So you want to make sure that you're treating UTIs because they can also lead to kidney stones. And there's a couple other ones in there, but calcium is going to be the predominant one that you're going to see with these patients. So risk factors, we talked about there being a higher incidence in males. There's also evidence to show there could be a family history. Prior history, of course, we talked about the 50%, your 50% recurrence rate. So dehydration can be an issue, immobility, urinary stasis, recurrent UTIs, so your patients that continue to get UTIs over and over again. And then excessive calcium in the diet. So think about what the stone is made of and what your patient's consuming, or any other recurrent diseases like gout. And think about hyperparathyroidism when you're thinking about that calcium. So that pain is going to be due to obstruction of the urine flow, and that also can result in quite a bit of distension and tissue trauma caused by the movement of the stone. So it can either be minor pain, it just kind of depends on the person and the size of the stone, so it might mimic a UTI, and it might be quite severe. Some of these can be quite painful. So you might have some hematuria with some of your patients, so blood in the urine, and that may or may not be the only sign you see in these patients. So really your signs and symptoms caused by urinary calculi are going to vary based on their size and location. So the manifestations can develop over time from obstructive urine flow, and that can really start to affect these patients. And they may have periods of time where they're not having any pain, just depending on where that stone is located. So if they're having major pain, that would be called renal colic, and that's going to be acute, severe, intermittent pain in the flanks. So think about where that is located at the time. So that's going to be an acute obstruction of the ureter, and that's going to result in some spasms. So it really is quite painful. It may radiate to the suprapubic region, groin, and genitals. So sympathetic response may also be involved. So these patients might be nauseated, they might vomit, they might have pale skin, so they might have some pallor and some cool, clammy skin. This major complication is going to be due to the obstruction, which leads to urinary stasis and infection, or even hydronephrosis. Testing with these patients, they're going to do a urinalysis to assess for hematuria and the presence of WBCs. They're going to be looking at the urine pH while they're doing that, which is useful in identifying the type of stone. They're going to do a measurement of urine calcium, uric acid levels, oxalate levels, and that's done through an observation of a 24-hour urine collection. So it's not listed on here, but that's one of the other things they can do is a 24-hour urine collection. And that is the amount of that's going to test the amount excreted and the time. It's going to be elevated calcium, could be due to hyperparathyroidism, Cushing's syndrome, or osteoporosis. And the uric acid level is going to be, of course, from gout, and that's going to help identify factors contributing to the stone formation. They're automatically going to do a culture with this just to rule out UTI, but it's more to get a more diagnostic level for the urinalysis here. They're going to be with these patients if they're voiding on their own and independently. You want to make sure that you educate them on filtering all of their urine. If they're in the hospital, you're going to be doing that for them. It kind of looks like a little funnel with a screen in the bottom of it, and you're just going to kind of put their urine through that to collect that stone. Once that stone's collected, you're going to send it down to lab for analysis. So they're going to take an analysis of this and see what that stone is made of, and it kind of fits along with this to kind of help determine what the cause is. They could be doing another IVP for these patients, a KUB, which is going to be an x-ray for kidneys, ureter, bladder, looking for stone locations, and they can help narrow down where that stone is located. With the patient, a renal ultrasound, that's going to detect stones and evaluates the kidneys for any possible hydronephrosis. So they want to look for a backup of urine in the kidney. And just think about that too, because that means that all that urine can't get out of the kidney, so it's just kind of sitting in there, and a cysto again. And lastly, they could also do a CAT scan, so they could be doing a CT of the kidneys with or without contrast, and that's going to show any calculi, obstructions, and other renal disorders. So this one would give the clearest picture about what's going on appearance-wise in the kidneys. So medications, you're going to be giving these patients narcotics to help with their pain. If they're inpatient and they have an IV, usually this is going to be morphine. NSAIDs like indomethacin suppository will help reduce inflammation. Also ketorolac, which is Toradol, and Motrin or ibuprofen to help with that. Anticholinergics or antispasmodics, that's going to be like oxybute, and I listed this separately just because that's one of the more common ones, but it also could be probanthane is going to be another one, but oxybutynin, that is going to be like your ditropan and your oxetrol. And then Flomax or tamsulosin, Procardia, that's the nifedipine, that is going to be used to help relax the ureteral muscles and promotes passage of the stone. Sometimes, too, they've been doing this new thing where they're adding thiazide diuretics just to help with calcium excretion in the urine. I don't see that all too common. It seems to be kind of one of those new things that's developing. So your nursing applications with these patients, you're going to really push fluids with them, 2.5 to 3 liters a day is what's going to really help to pass that stone. You want to educate them on their medications, to stick with their medication regimen, especially if they have gout. Educate your patients. I put this on here a couple times for a very good reason, because a lot of these patients are going to end up getting stones again. Diet, if they have a diet that's high in calcium, they need to be careful of that, especially with certain diseases like the hyperparathyroidism. That one's going to keep coming back. Compliance to their regimens, if they have UTI as a result of this, because think about the urinary stasis, they could be on antibiotics at home, so make sure that they're being educated on compliance with that, and then to strain their urine. And I really can't educate or stress education enough with these patients. And then lastly, which is going to be on the next slide, is we're going to talk a little bit about removal, and there's some videos for you guys to watch on a separate PowerPoint. So the PowerPoint without the voiceover is going to have all of these listed on here. So with these types of procedures, we're looking at stone removal. So there's a couple different options here. They could be doing a cystoscopy, a urolithotomy, pyelolithotomy, nephrolithotomy, and a lithotripsy. This one right here, the last one, the lithotripsy, is extremely rare. They don't typically do this one anymore. I haven't seen it done in years, honestly, but it is in your book, and they do talk about it, so it is in here. So with this one right here, what they're looking for is an incision that they're going to make in the ureter to remove the stone. And if you click on this, on the other PowerPoint, it's going to bring you to the procedure, and you'll see a very large stone being removed from a ureter. This one right here is going to be an incision on the kidney pelvis to remove a stone. So it's all based off of the location of it. And then This one is the preferred treatment for removing large stones. So you're looking at stones that are over 2 centimeters in diameter within the kidney. So that involves like a keyhole type surgery, and it's performed through a 1 centimeter incision with the skin overlaying the kidney. So they're going to be flipping them over onto their stomach to do this one. So make sure that you watch these. If you're interested in more information on it, you won't be tested on anything specific that you see on the video, just coming out of what's in your textbook. So aftercare for these, just as an FYI, because that's the part that's going to be really important when sending these patients home, you're going to educate your patient on incision site cares and monitor for signs of infection. Make sure that they're keeping an eye on their fluid intake and that they're voiding. And then I just have that little disclaimer in here. So bladder cancer, 90% of tumors in the urinary tract are going to be located in the bladder. And there's some major contributions to bladder cancer development are going to be carcinogens in the urine. So the other thing is going to be infection, but more than likely it's going to be carcinogens. So cigarette smoking is going to be the leading risk factor for the cause of bladder cancer, and that's twice. It basically is doubled that of non-smokers. So you think about the relationship between smoking and lung cancer, it is about the same for bladder cancer as well. So malignancy can develop in any aspect of the primary urinary tract from the kidney pelvis to the meatus. So that's going to be the opening of the urethra. But 90% are going to be in that bladder, with 8% in the renal pelvis and about 2% in the ureter or the urethra. So it's going to be a high survival rate if it's diagnosed early. So then the 5-year rate is going to be about 96%, and it's 4 times more likely in men, and it's usually over the age of 60. The other things other than smoking that can contribute to it are going to be occupational exposures to dyes or solvents. So think about your plastic, rubber, and cable industries, as well as textile workers, leather finishers, spray painters, anybody that works with petroleum. So lastly, it's going to be chronic UTIs and bladder stones can increase the risk. The risk also seems to be reduced by an increased intake of fruits and vegetables. So mom was right, eat your fruits and vegetables. With these, the appearance of the tumors, a lot of them are going to be papillary, and that's going to be a superficial polyp-like. Kind of think about the polyps that we saw in GI, and they kind of look similar to that. So that's going to be about 75% of the tumors. The other ones are going to be flat, and that's going to be the ones that directly invade the bladder wall. And I think what you're most likely going to see is that first type, so the papillary type. Those bleed pretty easily, and they're really invasive, and the prognosis and recovery for those are pretty good. So the flat ones, again, are going to be less frequent, and they invade other tissues. So they're associated with a poorer prognosis as a result of that. So if they do metastasize, it's going to be common to the pelvic lymph nodes. So think about the location, the lungs, the bones, and the liver. Manifestations, these patients are going to have painless hematuria. So whether it's gross or microscopic, that's going to be a presenting sign for these patients, and that's going to occur in about 75% of all of those tumors. So you might not be able to see it, you might be able to see it, just kind of depends, but it's going to be painless, so they will not feel any pain with that bleeding. So bladder wall inflammation is common, and that's going to have UTI type symptoms. So think about abdominal pain, back pain, that kind of thing. and then bladder irritation. So if there is a tumor in there, they're going to have some bladder irritation. They could also have some urinary obstruction by the tumor, and that can be what causes some of this low back pain and that colicky pain. Their other symptoms are going to be UTI-like, so they're going to have frequency, urgency, and dysuria. And most of these are not going to be discovered until they obstruct urine flow and cause flank pain. And the most common presenting symptom of this is going to be intermittent painless hematuria. So these patients are going to notice that there's blood in their urine, and that's what's going to make them seek medical care. Interdisciplinary care for this, we're going to be getting some testing. We're going to do a UA looking for hematuria. Urine cytology, that's a microscopic evaluation of the cells, and it identifies abnormal cells. So a lot of times with these, you can see the tumor cells in there. Ultrasound of the bladder, and they should be able to visualize any type of bladder tumor. They may also do another IVP here as well. That's a pretty common test for the urinary system, and that may reveal a rigid deformity of the bladder wall. So obstruction of the flow can be detected with that. Cystoscopy, again, and that's going to be for direct visualization, assessment, and possibly a biopsy, and that can show definitive diagnosis. And then a CT or MRI, and that's going to be used to evaluate any type of tumor invasion or MET. So they might also be doing a PET scan with that, but not initially. So medication for this, they're going to do intravesical installation of an immunologic or chemotherapy agent. They can instill that directly into the bladder if need be. They can also be doing radiation and surgery. So, like I said, this one's going to be directly into the bladder for the chemotherapy, and that's installed directly into the bladder, creating a local inflammatory reaction that eliminates or reduces a superficial tumor. So the treatment of early lesions is really what they're looking at, and prevention of recurrence. Other chemotherapies can be administered IV if needed, and that's going to be looking at more advanced cases. Other chemotherapies can be administered directly into the bladder. So some of the reactions that you might see with that are going to be bladder irritation, frequency, dysuria, and bone marrow suppression. And the radiation treatment's really an adjunctive therapy, and palliative treatment is given for inoperative tumors or those that are not good candidates for surgery, where they're going to be removing that. So there's a few different options here when it comes to surgery. So the resection is going to be a tumor resection. So they're going to remove that tumor. If they end up doing a cystectomy, that's going to involve complete surgical removal of the bladder and any adjacent muscles and tissues. And then at the time of surgery, they're going to create a urinary diversion that is provided and created and provided to help collect urine and drainage. So the most common type of that's going to be an ileal conduit. So they're going to end up with a urostomy if that's the case. So they could be performing a transurethral resection of the bladder tumor. So that will be to resect superficial bladder tumors by excision. If they end up doing a cystectomy, I can't even speak today, they're also going to be, in men, they'll be taking the prostate out and the seminal vesicles, and with women, they'd be doing a total hysterectomy with ovary removal. So over here on this side is a picture of what you would see with an ileal conduit. If you follow the kidney down to the ureters, that is a segment of the bowel that was removed and used to create a urostomy. So what they've done is they've taken a segment of the ileum right here, and that's separated from the small intestine and formed into a tubular pouch with the opening end brought to the skin surface right there. and the ureters are connected to the pouch. So right there. This forms a continuously draining stoma, which means that you have to wear an ostomy pouch with this. So post-operatively with these patients, you're going to be looking for edema because that can interfere with urine output, infection due to reflux, and you want to make sure that you're doing good skin care. So that involves stoma care. The stoma should be beefy red, same thing that you would find with your colostomies, that kind of thing. So beefy red, they may have slight bleeding with drainage initially, and then you really want to make sure that you're taking good care of them. So when you're changing these, you can always use a piece of gauze or a tampon just to prevent some urine leaking out onto the skin. You want to clean the skin with soap and water and keep the skin around the stoma protected, clean, and dry. And you're going to be emptying these about every 2 hours. Sometimes these patients will also have an NG tube in place just to be able to allow the bowel to rest. The other one over here, you can see that pouch over there. This is a continent urinary diversion. So a segment of the ileum is separated from the wall of the intestine and formed into a pouch. So you've got that little pouch there. They'll have nipple valves on there, and they're formed at each end by intussusception tissue, and that's when they, if you remember the intussusception from GI, that's when you kind of telescope it back on itself. So they do that to, they bend it backwards into the reservoir, and that kind of keeps it from leaking. So this requires clean intermittent catheterization every 2 to 4 hours. These patients are taught how to do that. So they must be able to do that and be motivated to do that. If they can't, then they're going to end up with an ostomy instead. So nursing diagnosis with both of these is going to be disturbed body image and a risk for infection. One of the things I wanted to show you guys, because you will see it, especially with people that have gross hematuria, people after a TURP, which is transurethral resection of the prostate, you're going to see patients with these CBIs in this CBI Foley. So it stands for continuous bladder irrigation. This is a really good video on that that illustrates what they're going to be doing in that, and this one's for Foley care. So with these, when your patients return and they have this CBI going, really maintaining accurate I&O is critical, because these bags, they kind of look like an octopus because you've got several bags up on an IV pole. It drips in by gravity, and there's about 3,000 milliliters per bag. So this has like a little regulator right here that you use to control the flow. So if they've got more bleeding, you would turn up the flow rate. This goes into the bladder and washes everything out. So it's keeping everything clear. So if you've got gross hematuria, those clots can tend to clog and the patient can't urinate. So this is kind of a prevention for this. So this goes in, washes it out, and then the result is going to be pink to red urine. If it's increasing in redness, you would turn up your flow rate. If it's decreasing, you would turn it down. And this is nurse regulated. The other thing to consider with this, if your patient has a lot of suprapubic pain, they feel like they have to urinate, make sure that you bladder scan them because they can get clotted off. And we'll talk about that a little bit more. They use these a lot with TURPs. And then there's another video here regarding Foley care. Lastly, for this section here, there's a little Jeopardy game that has some questions in here, kind of quiz your knowledge. You could probably do it online with some of your classmates even, so make sure you check that out. It's got some pretty good questions in there.